I ask maybe next time, please, less than 4 talks in one day. As I said before, I have my disclosures. I haven't done Tavi in a couple of years. David Holzai is our Tavi man right now, or our transapical man. But I am the assistant director at the hospital. We are the largest, I think in Europe, or definitely in Germany. We do about 4,000 pumps a year. And I'm also the guy they call when the shit hits the fan. So I've seen a lot of shit. That's all I can tell you. There are different Tavi procedural complications that can occur. There's vascular complications, which I briefly talked about this morning. I don't think we need to discuss much more. Residual regurgitation, which is a hot topic right now. Poor positioning of the valve. Annular rupture, aortic dissection or rupture, or VSD, all of which we've had, unfortunately, have had experience with it. You name it, we've seen it. Residual AI post-Tavi. Before, we didn't really talk about this, and if you went to TCT, you would think that residual AI is a good thing and that it doesn't really have any impact on patient outcomes whatsoever. And we also, from our transapical experience, tended to minimize the problem of AI. We feel that the paravalvular leak is a little bit less with the transfemoral approach, but I can't prove that to you with data. It's just my own rough experience. But here's echo data that we have on our Edwards Sapien transapical follow-up. The transfemoral core valve data it belongs to the realm of our cardiologists, and we've tried for a couple of years to get the long-term echo data, get them to share that with us, but for whatever reason, we don't have it. But this is what we have for our transapical Sapien experience, and you see that moderate AI that's combined transvalvular or paravalvular is about 5% or so and remains roughly stable during time. But that mild aortic insufficiency is in about 40% of patients, and that's certainly a lot higher than what we see with conventional aortic valve replacement surgery. And why is that important? Well, that's because of this publication. It's not in print yet, but it was EPUB, March 26th. This is the partner data, 2-year follow-up from the partner A. And I'm not sure which one of the co-authors here forced this issue as a figure into the paper, but I have a sneaking suspicion that it was a surgeon. And basically, when they analyzed patients' long-term survival of just the Tavi patients, so this is not the conventional aortic valve replacement, this is just Tavi patients, and they analyzed them according to whether they had none or trace paravalvular leak at the end of the procedure, or mild or moderate to severe, and you see any paravalvular leak had a significant effect on long-term survival. Surprisingly enough, mild had a very strong negative impact on long-term survival. And so that was paravalvular leak. This figure is now total leak, so paravalvular or transvalvular, and again showing that there's separation of those 3 groups. So even mild aortic regurgitation is not good. We subsequently went back and analyzed our own data as soon as we saw this paper, because we hadn't really thought to do that before, and we see the exact same thing. Mild or more paravalvular leak causes a separation of the survival curves during time. So why is that? I think that's a subject for another talk, but it's not hard to postulate that elderly patients that have these very thick hypertrophied ventricles that have been used to be seeing stenosis for 20 years, now all of a sudden they see aortic insufficiency, they don't tolerate it well. And one thing I can tell you from our experience is that if you have moderate or more aortic regurgitation in the operating room, don't wait and see what happens, because we've had that a few times. I said that we always have one surgeon and one cardiologist for every one of these procedures, but sometimes for the transfemoral procedures we have the chief of cardiology and we have a junior cardiac surgeon, and in Germany that's a little bit different hierarchy, and it's hard for the junior surgeon to tell the chief of cardiology that the valve needs to come out. But we've seen it a few times. It's a bad idea. If you say, okay, we'll just take the patient down to the CCU, because all of our transfemoral patients go to the CCU, they don't come to our ICU, and then just wait and see what happens. 6 hours later, they're in cardiogenic shock. You're behind the 8-ball. The patient's not going to survive their conventional operation. So what are the options for residual AI? Of course, there's conversion to a regular aortic valve replacement operation, which I think should be done whenever it's moderate or more. Reballooning is another option if it's a paravalvular leak, or a second valve-in-valve as a rescue procedure, and I'll show you some data on that. And just again to stress, more than mild AI is not a good result. So here's a paper that Jörg Kempfert published from our group looking at a second valve-in-valve as a rescue procedure, so not a planned elective valve-in-valve. And in this paper, we had 15 patients out of 305 transapicals. So it's an uncommon occurrence, but it is sometimes absolutely it is actually absolutely necessary in order to save the patient. And this was based on our previous experience whereby we knew that a sapien inside of a degenerated bioprosthetic valve gave good results. So in 7 of those 15 patients, it was a matter of the valve being implanted too low. So here's one example here. You see the valve sitting far too low on the far left with a severe paravalvular leak. A rescue valve-in-valve was quickly done, whereby we crimped the valve very quickly, loaded up, and implanted at a much higher level. And you see a very good result here with just very minor residual paravalvular leak. Here's another one, what I talked about this morning, and this is a problem that you are going to see occasionally. It's when a valve is put in that's a bit too low, not so low that you're having severe paravalvular leak, but low enough that the patient's native calcified valve or leaflet is impairing the movement of the leaflet of the implanted valve. So that's what you see here. You see the native calcium here, a large block of it, and it's lying over top of the sapien valve, and this leaflet here is not moving very much in comparison to the other two. What's the solution for that? Well, that's a rescue valve-in-valve with a slightly higher position, and as you can see in this example, we got a very good result from that. Perforation of the interventricular septum, we've seen that twice. And here's one example where the valve function is good. There's hardly any leak, but then we were quite disconcerted when we noted that the patient also had a VSD. So we went ahead and did a rescue valve-in-valve with a slightly lower position. And as you can see in the final sequence there on the right, the VSD is now gone. And that would be the only thing, Neil, from your presentation. That would be my only suggestion for that patient, that you've really fixed the guy's AI with his freestyle, which is not easy because a freestyle doesn't have markers, doesn't have radiopaque markers, and they don't calcify very much. Freestyle valve-in-valves are hard. But my only suggestion would have been to use a sapien, because you may get a chance that you not only cure his AI, but if you get the PET landing in the right place, you'll also block out his pseudoaneurysm. So here's another, what we can occasionally see is that the patient has a paravalvular leak despite the valve sitting in the right position. It's not a transvalvular, it's not being caused by a piece of calcified native leaflet, which is impending or prohibiting proper movement of the leaflet. So in a paravalvular leak situation like this, you can do reballooning with 2 more milliliters inside of the balloon, and as we show in this case, there is an improvement in the paravalvular leak, but it certainly hasn't disappeared. And if that doesn't work, that was required in 8.7% of our patients in that series that I showed you. If that doesn't work and it remains significant, then you should convert to conventional aortic valve replacement. Of those 15 for a rescue valve-in-valve, you can see that our overall valve-in-valve rescue approach was 4.9%, and that's quite a bit higher than the source registry where it was 2.1%. So we are quite aggressive about doing this when it's necessary. You do see that this is tend to be a very sick group of patients, and I don't know why that is, but they have a very high logistic Euro score and also elevated STS score. And also porcelain aorta we noticed in 40% of these patients. Again, I don't know exactly what the role of that is, but it was an interesting observation. Oops, I'm sorry about that. The results of those 15 patients, 4 patients died, so that's quite a high perioperative mortality rate of 26%. Although we were able to get a successful procedural success in 100% of patients. Sorry, the mortality is on the next one. The 80% of patients were also able to be treated without the use of cardiopulmonary bypass, and conversion to sternotomy was not required in any of them. However, as I said, 4 patients died. 1 died 1 day postoperatively from intestinal ischemia, 2 died of low output syndrome 2 and 10 days postoperatively. Both of them did have a lower EF before the procedure, but basically what it shows you, if the procedure doesn't go smoothly in patients with poor left ventricular function, then they're at very high risk. So those are the ones where you're not allowed to have a complication, a problem. And then 1 patient died on postoperative day number 5. Even though he was doing great, we thought everything was fine, he was one of the patients that I mentioned this morning that we found dead in the bed. And because of that, we are doing telemetry monitoring for 5 days post-procedure. 6-month follow-up, 1 patient died postoperative day 83 for an unclear etiology, and the other 10 out of 15 patients are alive and doing well during last follow-up. Sorry. Other complications that we've seen, I'll just show you briefly. Here's one that you don't want to see on the top left. You can see that the sapien is definitely sitting too low. Although the valve is competent, you're seeing it's lying right up against the anterior leaflet of the mitral valve. And then here's a further echo a couple minutes later. It's starting to slip. And then here's the last echo. That's not a good complication. That patient did survive, though, with a conventional replacement, aortic valve replacement. And interestingly, we went back and looked at his echoes more closely afterwards, and we found this, a very asymmetric calcification with a large ball of calcium in the right coronary cusp, whereas the non-coronary was relatively free. So we are a little bit concerned when we see very asymmetric calcification. And this is one more complication to show you. Sorry, get that to run again. We implanted it. Patient's blood pressure started to drop even though the valve function looked good. We saw something on the echo there that we didn't quite like, but we weren't really 100% sure what it was. Then we did a 3D echo. Patient's blood pressure is progressively dropping, and we're seeing, I'm sorry about that, doesn't want to run. We're seeing blood flowing in a place that we shouldn't see it flowing. Now it's stuck. In any case, eventually we saw a pericardial effusion. It was an annular rupture. We've seen 6 annular ruptures, and all of them have required either replacement of the aortic valve, conventional aortic replacement with the valve, plus or minus a patch repair of the annulus. 1 patient, I was really amazed. I came in and the surgeon said to me, well, you know, this is just coming, I can see it coming out from the non-coronary sinus. I'm going to try to just fix this from outside. The patient was on cardiopulmonary bypass, but he said, I'm going to put some big stitches in here. And I said, you know, well, I'm skeptical, but it was a very old patient and somebody that conventional surgery would have also been difficult, and it actually worked. They got the annular rupture to stabilize, and the patient left the hospital. So I apologize, my computer is freezing up there, but these complications can occur during TAVI, and sometimes require some very complicated solutions, but in about 2/3 of the patients, you can save the patients with good long-term results. Thank you.
Thanks very much, Michael. Very interesting data on the aortic regurg. Any questions for Michael?
Do you set pre-procedurally the criteria and the depth of surgical intervention you're prepared to undertake on a patient should a catastrophe occur? If so, do you have guidelines for that? Do you discuss it with patients beforehand, or do you wing it, you know, as these things occur? Because you've mentioned a number of times you've done some surgery replacements of the aortic valve to get you out of trouble, get the patient out of trouble. Some of which have gone quite well, it seems.
We do discuss with them a sternotomy and conventional surgery, and if they're not willing to have that, if they say there's absolutely no way for a conventional operation, then we won't go ahead and do the procedure because we can't guarantee it. We can't guarantee it. If they say there's absolutely no 100%, but that's very uncommon. I'm originally from Canada. I've worked on both sides of the Atlantic Ocean, and I can tell you, German patients tend to be quite trusting of their physician, and they tend to say, you do what's best for me. And when we bring it up that we may need to do a full sternotomy, then they are, for the most part, agreeable to it. But one thing we do figure out right away is if the depth of the aortics. So if they would agree to an ECMO, for example, we did have 2 patients with ECMO in our entire series. One of them actually survived, amazingly. And if they refuse that, that's totally reasonable. I would not suggest using ECMO for bailout.
But do you feel, from your surgical side, there are some patients that you will not, under any circumstances, go beyond putting on the bypass for an hour, just as you said before? Do you feel on your side you won't take it beyond that?
Yeah, there has been a couple of situations where we said it's hopeless. One was a rupture of the aortic arch, and we just called it quits right there and then. There was no sense. It was a reoperation as a very elderly lady, and the cardiologist was really pushing hard to get the thing around the arch, and it burst, and that was the end. There has been 1 or 2 other patients where we said, look, this isn't going to end nicely. Let's just stop it now.
One quick question from Ola.
Well, I think it's a very important point to agree on that before actually one does an operation. I mean, the reason I'm saying this is that I was always very amazed when I talked to a lot of other centers that often you go somewhere and the team starts to work on a patient, but they are not prepared for the moment when something goes wrong. I mean, whatever you do when something goes wrong, I mean, it needs to be carried by the whole team. So what I always trying to get in the mind of people is if you do it as a team, you as a team need to have a bailout strategy, whatever it is. And I believe that's what you're heading for. I mean, the problem is if you come to a scenario where nothing like this has been thought through, and suddenly you find a situation which is not carried by the whole team, then you're in a mess. And I think that mess easily can be prevented if the whole team has a clear idea.
I completely agree with you. No bailout strategy beforehand is a bad idea.